Welcome to the Outperform Cancer podcast, where we identify anti-cancer strategies found in peer-reviewed scientific research. My name is Mary Beth Gilliam, and I'm a metastatic breast cancer patient searching for ways to outperform cancer. I'm very grateful for the excellent standard care I've been given, but I'm also not satisfied with standard care results. I think it's possible for cancer patients to do better, and the people who can help us are cancer researchers. In each episode, we talk to a well-regarded, published researcher who's focused their work on a potential anti-cancer strategy that could be used with conventional treatment. Visit the Outperform Cancer website at outperformcancer.com to see all of our anti-cancer strategies and to sign up for our newsletter, which will alert you to new strategies as they're posted. Today, we're speaking to Professor Dr. Kathryn Schmitz about exercise and cancer. I asked Dr. Schmitz here to talk to us about exercise as medicine, and I challenge you to stay tuned for the next 10 minutes and see if you're not motivated to rethink exercise as an important anti-cancer strategy. Just how much can exercise impact your outcomes? Research suggests that on average, it can provide about a 30 to 50% risk reduction in recurrence. That range is derived from many different studies, and it takes into account that some cancers respond better to exercise than others. For example, a study of 1.4 million people found that esophageal cancer seems highly responsive, while other research for colon and breast indicates super strong benefits for preventing recurrence as well as improving mortality. But after considering all this data, years of research, thousands of studies, the research community is citing an average of 30 to 50% risk reduction in recurrence. And that's a very big deal. To help you understand just how big a deal it is, let's consider the effectiveness of the very popular breast cancer drug, anastrozole, which is used to treat hormone-positive breast cancer. According to breastcancer.org, anastrozole can reduce the risk of hormone receptor-positive breast cancer recurrence by 50%. So, in some cases, people who are exercising regularly are seeing risk reductions that rival cancer drugs. So, to be clear, I'm not suggesting that drugs can be replaced by exercise. I am suggesting that exercise is a very powerful anti-cancer strategy that can amplify other anti-cancer strategies like taking drugs such as anastrozole. So the question is not whether you want to exercise, but are you willing to walk away from one of the most impactful anti-cancer strategies that exist? I want to leave you with that question while I introduce Dr. Schmitz. Dr. Schmitz is a professor in the Division of Hematology and Oncology at the University of Pittsburgh School of Medicine. She serves as the Associate Director of Catchment Area Research. She's the co-leader of the Biobehavioral Cancer Center Control Program and the director of the Exercise Oncology Initiative for the Hillman Cancer Center. She's published over 350 scientific peer-reviewed papers, some in very prestigious journals such as JAMA, New England Journal of Medicine, and the Journal of Clinical Oncology. The reason I asked Dr. Schmitz to be on the podcast is not just because she's accomplished, but it's because she's an authority on using exercise to improve outcomes, even amongst advanced cancer patients. And she has experienced cancer through her wife, Sarah, so she's been through it personally as well. Her experience actually led her to write a book titled Moving Through Cancer, which provides cancer patients with a roadmap for how to exercise through cancer from diagnosis to preventing recurrence. She is the winner of numerous awards, most notably the Distinguished Scientist Award from the Society of Behavioral Medicine, the Citation Award from the American College of Sports Medicine, and the Clinical Research Professorship from the American Cancer Society. She is the past president of the American College of Sports Medicine, and she is just dynamite. You're going to love her. So without further ado, please join me in welcoming Dr. Kathryn Schmitz. Dr. Schmitz, thank you so much for coming today. We really appreciate your time.
You're so welcome. Thank you for the opportunity.
I know the patients out there are going to be very excited to hear about what you have to say. And I'd like to start talking about your personal goal. I know you are very committed to hitting this personal goal before you retire. Can you talk about what that is?
Sure, absolutely. So the goal is to make exercise standard of care in the setting of oncology, and we've set a goal of making that happen by 2029.
2029. And I know that you're very passionate about this. Obviously, if this is your personal goal and you're dedicated to not retiring until you hit it, which I'm going to hold you to, and I'm going to help you do it. But I know that you're very passionate about this. So can you convince us that it's an important anti-cancer strategy? Because I know there are a lot of people out there that have heard about exercise in the past. Yes, I know it's good for me, but I really think that they're not thinking about exercise as an anti-cancer strategy. So what do we know about the impact of exercise on cancer in terms of fighting existing tumors as well as overall survival for cancer patients?
So there's sort of three time points that we might talk about. And the first is primary prevention. So how do we, what do we know about whether exercise, physical activity has an effect on reducing the likelihood that someone would have an incident or new cancer? And the evidence base there comes from animal models as well as from observational studies. We don't have any clinical trials in this space because cancer takes a really long time to develop. And so the evidence that we have from clinical trials actually has to do with understanding whether or not an exercise intervention alters biomarkers that are thought to tell us that the cancer is more likely to develop versus less likely to develop. So that's the type of evidence that we have in the prevention space. And the evidence is really striking. And the evidence goes back a long way as well. So the first study that I'm able to identify that looked at this issue was an observational study from 1911.
Wow.
And yes, which showed that individuals who had more active jobs as compared to the more sedentary upper class in Minnesota at that time were less likely to develop colon cancer. And so we have had stunning observational evidence, particularly in the area of physical activity and colon cancer, for over 100 years at this time. And so I am absolutely convinced that being more physically active is associated with reduced risk for onset of colon cancer. We also have beautiful observational evidence for breast cancer. Interestingly, we do not have this evidence for prostate cancer. The evidence for prostate cancer comes in after the diagnosis of prostate cancer. Physical activity is very good after you've had the diagnosis, but we don't actually show a whole lot with prevention with prostate cancer. But there are actually 7 common cancers. Oh goodness, don't ask me to repeat exactly which ones they are. It's like trying to remember the dwarves, like Grumpy or something, but there are 7 common cancers that are, they are esophageal, cervical, endometrial, breast, colon,
That's
there you
okay.
go. And there's one more in there somewhere. Maybe kidney. I'm not entirely sure. I should know this, right?
You know what? We'll put that in the show notes because I know you've given me a beautiful chart that we can refer to. And so we'll make sure that goes on the website and in the show notes.
I also need more coffee. So anyway, so we have this really stunning evidence, and For primary prevention, we know that the order of magnitude we're talking about here is about 10 to 15% reduction in risk. When we get into the cancers and whether the cancers grow, the most beautiful evidence we have here is in animal models. And the animal model data really is stunning. That shows us that if we exercise animals and then compare them to animals that are not given a running wheel, not given access to any exercise in their cages, the reduction in tumor growth in the animals that exercise is anywhere from 30 to 70%, depending on the experiment and the particular model of cancer that we're looking at. But really just remarkable changes in tumor growth, very consistent study after study after study in animal models. The observational evidence in this area is also really, really compelling. We have beautiful observational humans being followed over a long period of time in cohort studies, humans being compared in case control studies. We have beautiful evidence that shows us that we have a substantive reduction in recurrence of breast, colon, and prostate cancers on the order of 30 to 50%, depending on the particular study, for individuals who are regularly physically active versus those who are not regularly physically active.
Can I ask a quick question?
Sure.
So what you were saying then, I believe, is if I've had breast cancer, which we know I have personally. So if I had breast cancer, and I was a regular exerciser, then I could expect a risk reduction of recurrence of between 30 to 50%. Is that what
That's
I'm
what I just said. That's what I just
that's what you
Yes,
just said. I
that's what I
love
just said.
that's what you said, because that's
It's
an incredible amount.
right, right. And so let me talk to you a little bit about the nature of the evidence. I know that we had planned to talk about this at some point, but I really feel sort of compelled to explain this. When we're talking about whether there is actually why should your listeners believe me? You know, what is the quality of the evidence? You know, did I just come up with this in my garage this weekend, or is this, something that's, well established in the science? So I want to make sure that people really understand the different types of evidence that can be brought to bear in this argument. There's a triangle of this, and I was taught about this by the inimitable Henry Blackburn, who was one of my mentors at the University of Minnesota when I trained there. And he talks about the three beauties, and the three beauties being clinical science. So those are the clinical trials, okay? The bench science, which is the animal model studies and the Petri dish studies, right? And the population science, the observational science. And the truth is that we don't really feel absolutely like we're ready to bang the gavel and say we're done with a topic until we have all three. But sometimes we don't have the option of having all three. Sometimes it just doesn't exist. It's not a possibility. So let me explain a little more about that. So with the tumor growth and recurrence data, we have animal model data that is experimental and, really the highest quality data we can have is a randomized controlled trial, right? So these are randomized controlled trials, but they're in animals. And animal models, while they are extremely important and really help us, like we're able to do things in animal models we cannot possibly do in humans because their lives are shorter, because things happen quicker in that model. So as a result, we can get some answers, but animal models do not perfectly recapitulate what's happening in the human being. There are a number of reasons why those models are wrong, are imperfect. They don't give us the full answer. And we see this over and over again, Mary Beth, because we see, we have results in animal models, and then we stand up clinical trials and it doesn't behave the same way in human beings.
Yeah.
And that just happens over and over and over again. And that is your evidence that the animal model does not perfectly recapitulate what's going on in the human. And so we need to know what's going on in humans. And so cancer is something that develops over the course of a decade or more. And so one of the ways that we can look at human beings and not be able to, if we can't follow them for a decade, which funding does not last a decade for any particular grant that I've ever had,
Yeah.
then we can do observational studies. And we follow people over time, and we watch and wait and see what happens, and we observe what happens. And those studies are very powerful because we can have thousands of people. My favorite study that I quote all the time about exercise and primary prevention of cancer had 1.44 million people in it.
Wow.
So
Okay.
we can put together these enormous, enormous groups of people, and it's hard to argue that you really are seeing something real when you have those kinds of numbers, right? But unfortunately, those studies are flawed because those studies, mean that, people did whatever physical activity they did. It wasn't controlled.
Hmm.
They are self-reporting, or we're getting, accelerometry data to tell us what kind of physical activity they're doing. And, we don't get to control how much physical activity they're doing. So they're uncontrolled follow-up studies, basically,
Yeah.
right? And then the third type of trial that we can, or study we can do, is a randomized controlled trial. And this is the most tightly controlled, highest gold standard that we have in order to move forward in our
Hmm.
scientific understanding. And although it's the gold standard, it's extremely limiting
Yeah.
because I can't follow people until they have cancer. I
Yeah.
can't. It's not possible the way that funding is currently organized, because it would take 10 to 15 years of follow-up. And who's going to sign up for that study?
Yeah.
How do you actually get human beings? If it turns out that it's easier to get rats to run on a wheel than it is to get human beings to go to an exercise class three
Yeah.
times a week. Uh,
Right.
so, so we have to pay attention as we're looking at the evidence. You've asked me, what is the evidence? The evidence comes from these three different areas, right?
Yeah.
And what we try to do as much as we can is bring those three together. To the extent that we can, we try to make sure that we have evidence from all three, and we try to see if we can triangulate across these three types of evidence in order to convince ourselves that something is really happening. And I am telling you that we have evidence from all three of these, or at least two of the three, for prevention, for tumor growth, and for progression of cancer.
Wow. That's impressive. So, in terms of a frame of reference, if in general, I'm someone who has experienced cancer, and you mentioned, 30 to 50% reduction in progression or recurrence, right? So, help me understand, how does that relate to some of the drugs that are out there? I mean, it seems as though that is um, if a drug performed that well, would people be jumping up and down?
They absolutely would be jumping up and down. And so, if exercise, I mean, it's a quote from the exercise is medicine movement, which, started at ACSM in 2007, that, if we could put the benefits of exercise into a pill, it would be prescribed by every doctor at every encounter. And it wouldn't be just about cancer, but we're talking about cancer today. So it would be prescribed by oncologists. The thing that we have to pay attention to is that exercise, while it has physiologic benefits that are very important in relation to cancer prevention and control, it is a behavior, and it is a volitional behavior. And undoubtedly, there are people listening to this who are jumping up and down that they are getting the benefits that, they thought they were getting from exercise. And there are other people listening saying, "Oh, does that mean I have to move?" So, shaping that behavior and helping people to figure out how to get this done is, raison d'etre at this point. It's got to be, one of the most important things that we do.
Yeah, and that circles back to your personal goal,
Yeah.
um, because this to me, of course, I'd heard my whole life, yes, exercise is great for you. Everyone should exercise, and you get used to hearing these messages. But what was surprising to me when I was diagnosed as metastatic in 2020, and I started to do more and more of my own research, was just how compelling the research is, and that exercise is medicine, and so even those people who find it difficult to exercise, and I have to say I still find it way easier to sit at my computer and do research than I do to get outdoors and do exercise. That's why I got a dog who requires exercise every day to force me to go out. But the evidence does seem so compelling that to me, that's what gets me off the couch. And I'm hoping that as we have listeners to this podcast today, that's what helps them get off the couch, that this isn't just something that's a nice to have, that this is something that's truly going to make a difference in your overall survival.
Yeah, so there's two things I want to respond to with what you've said. One is that there actually is research to show that dog owners actually have better health because they're walking their dogs on a regular basis. So good on you for the dog. So so walk your dog, get a dog. If you don't like working out, get a dog. That is a tried and true way of getting people to walk more. The other thing is that it's really important to communicate that I think that there is a sort of a behavioral psychological filter that people take, think that that the language goes through when we say exercise, when we say physical activity. And for me, it goes back to junior high gym,
Yeah.
and I don't know, there was a game that we played called crab ball. Does anybody remember crab ball? With these big giant cage balls. And anyway, so there were things that were uncomfortable because we were all pubescent and changing our
Yes.
clothes in front of each other and all of that. And I think that there is just a need to acknowledge the fact that we come in all shapes and sizes,
Yep.
and that exercise is good for us regardless of our size, and that the late great Steve Blair did seminal research to show us to prove the fit fat hypothesis, which is that it doesn't matter what your BMI is, it doesn't matter how large you are. Physical activity has physiologic benefits regardless of what your weight is. And so I think it's really important for your listeners to understand that a little bit of exercise helps. We know that we get greater benefits going from nothing to 10 minutes a day than we do going from 30 to 40 minutes a day, for example. So it really doesn't have to be a marathon. It can be a 10-minute walk a day, and that can be your starting place. And once you're comfortable and that's gotten to be easy, then you build on that. So we need to really pay attention to behavioral shaping and how we help people to do just the tiniest bits of exercise in order to get them started.
Yeah. I think that is super interesting and super important. Now, correct me if I'm wrong, because I may have this incorrect. But I believe that also if you haven't been doing any exercise and you start doing some exercise, that you actually get even more benefits than someone who's exercising all of the time and just maybe does a little bit more. So if you haven't been doing anything,
Correct.
just starting something, you're going to benefit the most, right?
Yes, yes. There are a whole host of physiologic benefits that occur immediately. It's not something that you have to do for 12 weeks in order to experience the improvements in blood chemistry. So our blood glucose is altered. The way that the body deals with sequestering glucose within the cells is altered as a result of an acute bout of exercise, a single bout of exercise. The way that our inflammation system, if you want to call it that, works is altered by an acute bout of exercise. The immune system is altered by an acute bout of exercise. Myokines, which are the chemicals that are released from the muscles, are altered by an acute bout of exercise. I think there's another aspect here, and I think that this is sort of our best friend in this situation, Mary Beth, and getting those who are reluctant off the couch, and that is you actually do feel better. So, I mean, just think for just a second, how do you feel? Like nobody is built to sit on the couch all day. Nobody is built to sit in a chair all day. Nobody is. Nobody is. And it turns out we are meant to move till the moment we take our last breath. We need to move people in the ICU. We need to move people who are palliative, who are in hospice. Those people need to be moved, literally moved, right? We are meant to be in motion our entire lives. So if, do you feel better when you're just sitting all the time? And so the test that I would give to your reluctant listeners is get up for 5 minutes and move, and, dance, do something joyful, something that, makes you feel good, whatever it might be. Nothing that feels like a slog. And, you finish the 5 minutes and then just test, do you feel any better? Do you feel any different than you did when you were sitting on the couch? My guess is people are going to feel better. And if you feel better, then pay attention to that and let that help you to overcome the resistance.
That's right. Really acknowledging, the small wins and where your body is at. That has helped me a lot. I tend to go for a hike with the dog outside. I live in Vermont, which has got a lot of hills,
Right.
a lot of hills to climb. So we get out into the woods, and even on those days where it's very cold, like it is today, and it's hard to motivate, once I'm out there and then I come back, I always feel better. So
Always.
always. I before we move on from some of these statistics, I did want to note one more thing. In a study that you had provided to me, I noted this, that compared with women who were inactive both before and after diagnosis, women who increased physical activity after diagnosis had a 45% lower risk of death.
Yeah.
Uh,
Yeah.
and,
Yeah.
and so that's um, you know, pretty incredible. And then it continued that, and women who decreased physical activity after diagnosis
Mhm.
had a fourfold greater risk of death. So it's that turning, you've had a diagnosis. Once you've had a diagnosis, don't think that, oh, it doesn't matter now.
Mhm.
It matters more than ever now, right?
Right. So two things.
Yeah.
One, um, it's important to put this into context.
Okay.
Um, Understand that it's observational, and so there is the possibility that people self-select.
Okay.
So there is the possibility that the people who were able to exercise did so, and that they did better, and that the people who were unable to exercise did not do so, and they actually, it actually is sort of a chicken and egg
Uh-huh.
situation.
Yep.
So if you're not able to exercise because you're not doing well, then
Mhm.
those are the people, that's the signal that tells us that you are more likely to have recurrence. That is the downfall of an observational study. That's
Yep.
something you can't get past with an observational study. But
Mhm.
very important observation that you've pointed out is that it does matter after diagnosis. So prior to the study that you're talking about, what we had was data that told us that women who were more physically active were less likely to die of their breast cancer, but all of the observational physical activity happened before the diagnosis. So we thought it was just the pre-diagnosis exercise that made a difference. And what this study showed us was, nope, it turns out what you do after your diagnosis matters a lot. It matters a lot. So if you are able to exercise, it's actually it's sort of an interesting litmus test, isn't it? Like if you're able to exercise, then you really need to be exercising because we know it's really valuable to you. If you can't exercise, then you can't exercise. And, I just want to acknowledge that there are going to be people listening who can't.
Yeah. Yeah.
And
And let's
okay,
define exercise too, because I
right.
believe that it's not about going to a CrossFit class.
It is
Where,
not.
exercising for some cancer patients could be getting the mail, walk, right? It
You bet.
could be walking around the block. It could be, small things, but that gets your body moving.
Yes, absolutely. So if I can give a plug to my book, there is a
Yeah.
connection from my book.
Let's
Um,
talk
my,
about that,
my book
please.
is called Moving Through Cancer, and there's a website associated with the book, and there are some videos on the website that would be helpful to people who are they're intended for people at lower function. But in addition, if you buy the book and go on the website, you can get in touch with me, and you can get a free subscription to an online service called My Victory for a full year. And there's thousands of videos that are intended for people at all levels of function. There's chair exercise, there's everything from very low function level movement all the way up to HIIT training. and very, very intensive classes on my victory. It's intended, it's pitched as Peloton for cancer survivors.
I love it. I love it. And I think that is so important. And it's very much a part, it's at the core of my mission, my personal goal, which is to bring actionable anti-cancer strategies to people who have cancer or who are trying to prevent cancer. Because I feel like sometimes things are a little vague. We read some great articles and some new piece of evidence comes out, but you end up wondering, what do I do with this?
Right.
And the reason I reached out to you specifically was because I loved your book. I loved that the whole book, just for the listeners so they understand, is prescriptive. Like, you provide people with a path forward. If you've had surgery, here's what you want to know and what you want to think about. If you're in chemotherapy, this is what you want to be thinking about. So there's something for everyone at every stage in the cancer process. And then you also provide a context for this because you've experienced cancer in your own family. We've talked about how your wife Sarah was diagnosed and that journey. Can you talk a little bit about what motivated you to write this book and what you want people to know
Yes.
about it?
So my wife's diagnosis changed my career. It really, my career took a left turn as a result of it. So it was 2016, and Sarah was misdiagnosed for a full year. And when she was finally diagnosed, she has stage 3 squamous cell carcinoma in her right nostril, which had migrated across the septum and was considered, invasive and advanced. And she had what is euphemistically called a complete rhinectomy. The joke "got your nose" is not funny in our house. And she had her entire nose removed. Turns out in India, they used to cut off people's noses for theft. And so back in India, they developed, thousands of years ago, they developed a surgery called a forehead flap, where they would take a piece of the forehead and flip it down to form a covering for what used to be the nose. And that is in fact what they did for Sarah. They created a new nose out of parts of cartilage of her ear and skin from her forearm. And so this intensive surgery. And then they did combined chemo and radiation after that. And when she first was diagnosed, my mom had a squamous cell carcinoma on her nose, and it was just a little surgery, a little thing, and so when she said it was squamous cell carcinoma, I was like, oh, it's fine,
Yeah.
fine, it'll be fine, And we were in total denial until we walked into a room with medical oncologist, surgical oncologist, radiation, multidisciplinary team came together to talk to her about what was coming, and they were talking so seriously, and we were like, this seems like overkill. What we're doing. And it was our first clue, and the penny finally dropped when Sarah was in the room with the surgeons, and they kept talking about that they were going to take the tip of her nose. And this story, I know there will be many people listening who will really relate to this story. So, surgeons are very euphemistic, right? So they say things in the most positive possible way, and so they kept saying tip of your nose, and I don't know about you, but the tip of my nose,
Right, just seems like a teeny piece right
like,
here.
oh, you're just going to take the tip of my nose, it's all going to be fine, I'm just going to have the tip of my nose gone, right?
Yeah.
And they kept speaking to her in this very serious tone, and she was like, this doesn't track. And she said, finally, would you please draw on my face what you're going to remove? And they drew the entire nose. They like put a marker around her entire nose, and she was like, completely nonplussed and blah, and came out to the car and took a picture of it and sent it to me and was like, they're taking my nose, my whole nose. And we just went into panic mode. We just went into overwhelm mode. And And there were 4 weeks between when we had the seminal diagnosis, and we knew what was going on, and when she had her surgery. And that those were 4 key weeks when we could have built up her physiologic capacity for her to get through the rest of the treatment. And we
Her
completely
strength.
missed it. Her strength, right?
Strength.
Yeah, her ability to withstand the rest of the treatment. And she's a tiny thing, 5'2", 120 pounds. And we missed that opportunity because we were so overwhelmed. And it was only when she was actually in the process of doing combined chemo and radiation that, she started saying, God, I'm just so tired. I'm just so tired. And something kind of clicked for me, and I went, oh, wait, I know something here. I can be helpful, and I made her get on the treadmill for a half hour every day. And she really did not like it very much. But I'm very proud to say that Sarah got through combined chemo radiation without a single delayed or reduced dose, which is very unusual. It's very
Yeah.
common in head and neck cancer to have reduced dose and delayed doses, which are associated with worse recurrence and worse survival.
I was going to say it's super important to
Super
stay
important.
on regimen
That's
for
exactly
all
exactly right.
cancers,
That's right. Right.
so
So
that you get the benefit of the
yeah,
medicine.
exactly. So what I recognized in a brand new way because of the experience that we went through was that, I had been doing, efficacy trials to show that exercise was useful in the setting of people living with and beyond cancer for over a decade at that point, 15 years. And what I realized is this is all spinning in the wind right now because cancer patients are not getting the message. And so her diagnosis was in 2016. I got my book deal in 2018.
Wow.
So I was like, I am translating. I am translating. Now,
So,
that doesn't mean we don't need more science. We
right.
certainly need more science, but we know enough that people should be at choice about whether they actually choose to exercise in order to improve their health as they're going through their cancer journey.
So did anyone ever say during the process of being diagnosed and Sarah hearing from all these doctors, did any of the doctors say, you need to start exercising, you need to build up your
Not
strength, this is going to be
one.
taxing on your
Not
body?
one. Not one.
Not one.
Ivy League institution.
Yeah. And do you think that that's abnormal? Was it just,
No, I
unfortunate
think
for
that's
Sarah? Do you think that's what happens today?
standard of care. And actually, a really beautiful survey that was done by Jennifer Ligabell in collaboration with the American Society of Clinical Oncology tells us that when you ask patients, did your doctor tell you anything about exercise? 15% of patients report that they recall that their oncologist said something about exercise.
So only 15%.
15% are hearing about it. 15%. That is so low. That is so low. Despite the fact that oncologists, Jennifer Ligabell again with ASCO, did a survey of oncologists to say, do you think this is important? And close to 80% of them said yes. So they think it's important. They're just not getting to it.
Yeah. And it's interesting because I've heard, I've spoken with some oncologists about this, and I hear from doctors kind of almost a depression that they don't believe that patients are going to listen. They feel like there's really nothing I can do. I know if I give them a drug, it's going to get in their system, but I talk to them in exercise and I feel like it's falling on deaf ears.
Okay.
Okay.
But I got to step in here. I got to step in because listen, if you were to do with exercise, with chemotherapy, what we do with exercise, you would say the same result. What we do with exercise is we give people a brochure. So let's just do a thought exercise for a second, Mary Beth. Okay.
Yes.
This really,
get riled up.
Yes, I'm riled up. So, let's just do this thought exercise. Okay.
Yes.
We're going to give people a brochure for chemotherapy. We're going to say, this brochure will explain to you what chemotherapy is. We think it's useful for you and that it might reduce your recurrence of your disease. They have classes at the YMCA. They're offered at 7:00 at night, 3 times a year. I hope that works for you and that you have transportation to get there. And, good luck to you and goodbye, or Better yet, we think this will help you. The brochure will tell you what to do. Now, hopefully, I'm not suggesting we do that with
Yeah,
chemotherapy. I did
I
that
understand.
in order for you to understand that there is an enormous, enormous infrastructure around chemotherapy.
Yes.
So there's this enormous infrastructure that tells us there's a place you go in the hospital for chemotherapy. There's an infusion suite. There's a thing called a chemo chair. Like,
Yes.
did you know that that's a new invention? It's a
Yeah.
relatively new invention in the world, right? So there's a chemo chair. There are chemo nurses. There are people specifically trained to do this. Medical assistants have been trained in order to take the vitals and to flow people through the process. And there's a whole flow of what happens. Everybody who's been through this knows that there's this sort of, you go, you sit, you get your
Yes.
vitals, you sit down, you see the doctor, you go back, you
Yeah.
get in the chair, you're in the chair for however many hours, and there's
Right.
nurses that come by and they hang various bags, and they're
And they
checking
check
on
on
you.
you.
Right,
And they,
exactly, exactly. Well, if you had that kind of infrastructure for exercise, do you think people would do it?
I do. I do think they
There
would do
you go. So don't tell me they just won't do it. They won't do it because
it.
there's no infrastructure around it.
I totally agree. I also believe that there are, and I believe this is supported by research as well, which is there are points in our lives where they're pivotal for change, behavioral change,
Right.
right? Big moments in your life, like getting married, starting a new job, having a child, but also getting diagnosed with cancer.
Cancer. Yeah,
Getting diagnosed with cancer is a pretty big motivator to
it
get
is.
off the couch
It
and
is.
to do something,
Yeah,
right?
yeah.
So I feel like sometimes people are giving up on cancer patients, or doctors may have given
Right.
up on cancer patients without giving them a chance
Right.
to really understand the impact of
Mhm.
exercise
Mhm.
and to help them get started and do a new behavior, support that new behavior, which is one of the reasons I wanted to start off with you talking about statistics, because
Yeah.
I also often hear people say, oh yes, exercise, I know, there's a lot that's written, it's good for you, but
Mhm.
I think it's different when you tell someone you got a 30 to 50% likelihood of preventing recurrence.
Yeah.
Like, that's motivating, and I don't think that type of communication is getting through to patients.
I don't think it is either, but I also think that we need to, I want to be very careful about blaming the oncologist because
Yes.
I
Mhm.
just spent 3 years. I had the honor of being on the small group that helped to revise the standards from from the National Accreditation Program for Breast Centers. And it was a re-envisioning of those standards towards the goal of improving the patient journey.
Mhm.
And one of the things that came really clear to me, and that I want to acknowledge, and that I want to make sure that folks listening know that I understand, is that oncologists, there are too few oncologists for the number of patients, and that's just going to get worse as the nation gets older. And so they're pressed for time. And so the idea that they now also need to be physical activity counselors is untenable.
Yes.
And so they're going to deal with financial stress. They're going to deal with sexual health. They're going to deal with sleep. They're going to deal with cold caps. They're going to deal with exercise, nutrition, anxiety and depression, transportation issues, social determinants of health. I mean, there's a list of 15 things that NAPBC came up with, and was like, well, and why would we talk about exercise before we talk about everything else? And I have two answers to that. One answer is we need to build in the infrastructure so that there is actually a human being in place to be able to navigate people, a rehabilitation navigator, to be able to navigate people to the appropriate programming, whether it's a physical therapist or an exercise program or an exercise guide of some kind. The other thing is that I think that the reason why we should be doing exercise on top of all those other issues is the evidence.
Yeah. That's
Like, if I was just on a major call, national call with oncologists and and, folks interested in survivorship. And I said, our survivorship guidelines for the nation should be evidence-based. Everything that we have in there should be evidence-based. And somebody said, well, then that's rehab and exercise, isn't it? And I said, yep, that's exactly right.
Yep.
So, I think that, when you give me the list of 15 things that the oncologist should be talking about,
Yeah.
and the question is, why is exercise on top of it? The answer is because the evidence base is there.
Yeah, it's there. And I, want to just reiterate, I am so grateful for the care that I've been given. There's no doubt. I happen to have a doctor who is excited about exercise as a therapy as well. So that I was very lucky that way. But I do know, oncologists are doing an incredible job, and there's a lot on their plate. And I 100% agree with you. The infrastructure needs to be built to support this, just like the infrastructure is built to support other drugs, whether it's CAR T or chemo or, all of these different anti-cancer strategies. No one would expect it to move forward without infrastructure and expertise. And should be no different.
This should be no different. It
That's
is,
right.
yeah.
That's right. So, you were talking about your book, and you were talking about the ability to get patients to be able to see these videos, that you're kind of creating an environment or resource for them, if you will, where they can go and learn and take more into their own hands. I just wanted to come back to that briefly so that we could reiterate, where do they go if they want to do
Okay.
this? If you would tell them exactly what that is and the support that they could get through
Sure.
website.
So the agreement that I have with My Victory is that if somebody buys my book, there is an email address to send me an email to say, here's the code that says I bought the book. And you can buy it on Amazon. You can buy it on, in person at Barnes and Noble. It's where books are sold.
Yeah.
And you send me that code, and I then send the passcode that allows you access to My Victory. So the steps are: buy the book, go to the website, and it will give you the email address to be able to contact me. The website is plastered all over the book, but it's www.movingthroughcancer.com.
Okay.
So that's the website.
Okay. And even if it's a audiobook, if you get the
Yeah,
audiobook, does that
we
still
did
work?
do. We did.
Okay, great. I got the audiobook. Okay, good. And Sarah is doing well now, right?
Sarah's great. She's 7 years out, and she's disfigured. It turns out that when you irradiate tissue, it shrinks, and so she has a little nubbin of a nose. But besides that, she is extremely healthy. She has long-term effects. She gets cataracts more often than anybody else I have ever heard of, because of the radiation effect on her eyes. And her teeth were affected. So these are very, very common things coming out of head and neck cancer. But she's thriving. She's an architect and thriving in her career, and very healthy, exercises a lot. Her particular form of exercise that she got into because of her cancer was boxing, because she
Oh,
was so angry.
I get that.
Yeah,
I
so
get
she
that.
really enjoys boxing a lot. So,
I actually, I have been a student of Taekwondo for about
ah,
10 years. Um,
ah,
and
yeah.
I've done it with my younger son. And it feels really good sometimes to
Yeah,
throw punches and kicks.
yes.
That definitely helps with getting rid of some of that energy and directing it in a positive way
Right,
for
right.
your body. And that actually brings up something else that I was hoping we could talk about, which is types of exercise.
Okay.
So we know from our earlier when we were talking that all exercise is good.
Mhm,
Moving is good. I'm sure that's why you named your book Moving Through Cancer.
mhm.
But there has been specific research done um, on different types of exercise, meaning aerobic exercise and certain like minutes per week versus anaerobic exercise or lifting weights. And now there's a lot of chatter around vigorous exercise and then interval training like HIIT exercise. So can you touch on those things and tell us, like, is there one gold standard? Should we be doing one versus another? Does it matter if we're pre or post chemotherapy? Is one better at one point in time? How do we look at the types of exercise and decide what to choose?
Right. So, outstanding question. And I think it's really complex, and I think that, it's easy to get lost in all of this. So I'm going to go across the cancer control continuum and talk about this a little bit, and then I'll finish off talking about the vigorous exercise and HIIT training.
Okay.
But I want to talk about aerobic and resistance first. So, when we talk about exercise and primary prevention of cancer, we are entirely focused on aerobic exercise. And so if your listeners are pre-cancer, they have not had a diagnosis of cancer, and they're interested in the cancer prevention benefits of exercise, we are focused entirely on aerobic exercise. What I'm trying to convey is that that's what the research shows. That's not to say that there are not benefits of resistance training, but all of the studies that have been done that have focused on anything having to do with physical activity or aerobic or exercise of any kind, and cancer prevention in the animal model as well as in humans in observational studies has focused on aerobic exercise. One of the reasons for this is that it is very difficult to monitor resistance training exercise in the same way that we monitor aerobic exercise. It's very easy for people to recall, I went for a run 3 times last week. It's much more difficult for us to record the volume of exercise. It's much more complicated to say 8 exercises, 3 sets per exercise, 8 repetitions, at 50%, 1 rep max.
I see.
Very, like, it's difficult for people to know. They're like, yeah, I went to the gym, I lifted weights. And somebody could be going to the gym and lifting pretty pink dumbbells, and somebody could be going to the gym and doing very heavy barbell work, and so it's unlike, if you say you go for a walk versus going for a jog, we have a fairly good idea of your intensity, right? So there's some complexities. It's also exceedingly difficult to get rats to do weight training.
Yes, I can imagine.
There are some models. Out there, but they're rare. So most of the prevention research is really focused on aerobic exercise. So if your listeners are interested in primary prevention, it's aerobic exercise that I recommend. Okay, and that's what American Cancer Society, American College of Sports Medicine, all of the major organizations, that's what they recommend is aerobic exercise, anywhere from 150 to 300 minutes a week. If you don't have 300 minutes a week, do a higher intensity. And do 150 minutes a week. So that's the prevention. Now, once you have been diagnosed with cancer, it really depends on where you are in your process. So let's walk through the process and what you really need to be focused on as you're going through the process. And then we'll talk about recurrence and get back to the recurrence. Okay. Great. So the sort of standard, it doesn't always happen this way. Certainly there's neoadjuvant treatments. There's many different pathways that people have, but the most common pathway through cancer is surgery, chemo, radiation. Okay. So let's do it in that order, just for the sake of an argument. So for surgery, prior to surgery, you need to be hitting the gym. You need to be working as hard as you possibly can. Prehabilitation has been shown to be extremely effective, particularly in the setting of colon cancer. There's emerging evidence in lung cancer. Not as much evidence, not as strong an evidence as in breast, because people who are approaching breast cancer treatment are typically pretty well to begin with. But people who are approaching colon and lung cancer surgery are typically pretty debilitated, and those folks are more debilitated than the average breast cancer patient. So doing a combination of aerobic and resistance training is highly recommended and shown to be efficacious. And so it is the combination of the two and working as hard as you can without getting hurt for the 3 to 4 weeks. This is the window that we missed for Sarah, that I regret, And so, what I lay out in my book is actually a 3-week plan that can be expanded to, 6 weeks if you've got 6 weeks before surgery. So that's the most intensive moment of training in the process of going through cancer treatment.
So trying to build up before you have this surgery and your body is thrown into a state where it's going to have to handle a
Right.
lot.
And you're going to rest a lot. You're going to need to rest a lot. And so we lose physiologic capacity in the period of rest that must follow major surgeries. And so you're basically building up what you can so that the deficit that you have doesn't go as deep, right?
Yeah.
And then there's the period of recovery. And a lot of people misunderstand that after surgery, they need to be completely and totally sedentary for a very long time. And that is not accurate. They should be moving. Sarah was, doing laps in the hospital the day after her surgery with her IV pole, just lapping around, for a good amount of time. And we were really shocked that she was alone. There wasn't anybody else getting out of bed. So there are many, many studies that show what's called ERAS, enhanced recovery after surgery. We know that nutrition and exercise are crucial elements of ERAS protocols. And so we need to be getting people out of bed sooner. And we get out of the hospital quicker if we get out of bed sooner as well, which, getting out of the hospital is a good thing. Hospitals are a place where C. diff happens. Hospitals are a place where infections happen, bad infections happen.
And I think people feel better mentally when they get into their own home. So being able to move quickly from surgery to your home environment where it is a positive thing, and moving will help you, even walking around on the floor of the hospital.
Absolutely. After the surgeon says that you are able to return to normal daily activities, you should be back to doing aerobic plus resistance training exercise. And it's the plus resistance training exercise because you have lost muscle mass, you have lost strength. Okay, so there needs to be a combination of aerobic exercise and resistance training in the recovery from surgery. When you're going through chemotherapy, the evidence base tells us that there is value to aerobic exercise and to resistance training. And there is actually enough evidence, there's so much evidence that you can sort of dial into, well, what is the outcome you're caring about most? So if you care most about sleep, then it turns out that it's really aerobic exercise that is more important. If you care about lymphedema, then it's resistance training that you might care about more. If you care more about anxiety and depression, then it's either one. It turns out that they both work really well. So ideally, what you're doing during chemotherapy and immunotherapy, I will say the evidence base about exercise and immunotherapy is, to say scant is too strong a word. It's very, it's not there. It's just not there. So I don't talk about it in my book because the book is evidence-based. There wasn't any evidence to talk about, so I couldn't talk about it. So
it's very new. It's newer, right?
It's
just
newer.
we just haven't had the time to collect that information.
The studies are coming. They're coming. But during chemotherapy, the best case scenario is that you're doing 3 times a week, 30 minutes of aerobic exercise, which could just be, shuffling around the house, going to the corner store and back, or to the mailbox and back, depending on your setting. And twice weekly aerobic exercise. Those can be put into one session. So you could be doing 30 minutes and then 10 minutes of aerobic of resistance training, and then you're doing 3 sessions a week. But there needs to be acknowledgement of the fact that there are going to be times when you have bad days, and what we call, bad days. And bad days are days where it's like, nope, getting off the couch is really not an option today. So if you have a question, if there's a point at which you say, I don't know if I can do it today, then you should move for 10 minutes. Try to move for 10 minutes. If you feel better or feel the same, keep going. If you do not, then sit down, and you've tried and you're having a bad day, right? So, bad days that are bad days, fine, that's fine. Bad days, you're like, not sure, you give it a try. And otherwise you should be moving, and it should be a day by day by day thing, because as we go through chemotherapy cycles, and chemotherapy cycles can be 3 weeks long, they could be 1 week long. So it just really, it depends on, kind of the way that your particular chemotherapy cycles progress and the way that your symptoms progress as you go through your chemotherapy.
Mhm.
Once we're done with chemotherapy, the option is there for some cancers to go on to radiation therapy. The primary symptom that people report as they're going through radiation therapy is fatigue. And the number one treatment for cancer-related fatigue is aerobic exercise. But resistance training exercise also helps. So you can do one or the other, ideally do both. Again, 3 times a week, 30 minutes plus twice weekly resistance exercise as we get through it. When we're done with treatment, when we're done with all treatments, all various therapies, we want to migrate our way back to 150 to 300 minutes a week of aerobic exercise and twice weekly strength training in order to reduce risk of recurrence and cancer mortality.
You said something that I wanted to come back to, which was about building up the loss of muscle mass.
Right.
Because my understanding is there's some pretty strong statistics that suggest that losing muscle mass is detrimental to overall survival.
It is indeed. Yeah. So we worry a lot about what's called cancer cachexia, which is to say a loss of muscle mass, a loss of muscle strength and function, loss of grip strength. And those things are absolutely associated with worse cancer, more likely cancer mortality, worse recurrence rates. And so muscle turns out to be hugely important. Also important is what's happening with your fat mass. Fat mass can creep up as we're more sedentary, as we need to be more sedentary as we go through the more intensive cancer treatments, the surgeries in particular.
Mhm.
And so, or high dose chemotherapy, which is true for, a subset of patients as well. Those going through bone marrow transplants or, losing a tremendous amount of muscle as they go through, and, trying to keep them moving as much as possible as they go through that is hugely important.
Mhm.
So, yeah, it's cancer cachexia you should have somebody on who's an expert on cachexia because it's a huge new topic.
Okay. Yeah, I will do that. So building back the muscle. So we start off and we try to build up as much strength as we can, both muscle
Right.
mass and endurance through aerobic and anaerobic exercise before anything happens. Even if it's 3 weeks, you're going to
Yep.
get benefit
Yep.
even for 3 weeks of
Yep.
doing something. So
Yeah.
then that tries to mitigate the slope afterwards once we have had surgery and we do lose muscle mass and we start to become weaker. And then as soon as we can, and that means is that even while you're still in the hospital, you start moving, you
Mhm.
start getting your body just getting used to being in motion, and
Mhm.
then you start to add back, it sounds like,
Right.
and add on to.
And the tripwire to tell you that you've gone too far is that your wounds begin to bleed more.
Okay.
That if you develop infection, if you have blood seeping, new blood seeping from wounds, then you're pushing too hard.
Okay.
So what we're talking about in the early recovery from surgery is ambling with your IV pole.
With your IV pole. So,
We're talking about very, very low intensity movement
and then just building,
and
building
building from there. Yeah.
and building from there. So this is all very interesting, and you touched on a few things that suggest. Do we know why it works? Like, oftentimes scientists will talk about the mechanisms of action. It's I can see that we have the evidence base that something's happening. Do we know what's happening?
Yeah. So again, going back to that sort of triangle of the different, ways, we do biomarker studies in humans, so we can look at mechanisms of actions in humans, but we can't follow people all the way to cancer, and so there's a flaw in those studies. So we rely a lot on animal model studies for our mechanisms of action. And again, those do not perfectly recapitulate the human. So we're dealing with less than perfect data at all times with this. And that's true of the drug studies as well. I mean,
Yeah.
this is not unique to exercise.
Mhm.
It's true of nutrition studies, and so caveat, right?
Uh-huh.
So there are a number of things that we know happen when we think about the physiologic changes in the body that occur as a result of doing regular exercise. Most people would immediately see, oh yeah, you're going to have a benefit for your heart. Your heart is going to change because you're pumping blood in a different way. You're going to, people would sort of very easily understand that you would have a change in maybe blood vessels in the body, and the number of blood vessels, the density of blood vessels. It would be easy for people to see that the lungs would be, improved in some way. Lung function would be improved with regular exercise. It would also be probably pretty intuitive to people to understand that your muscles and bones are altered as a result. Might not be particularly surprising to your audience to know that your gut is altered as a result of exercise.
The gut microbiome.
The gut microbiome, absolutely. But also just gut function is altered as a result of being regularly active. But there are a couple of other tissues that are hugely important for the development of cancer and the progression of cancer that are also altered. There are the way that cancer develops is through a series of tripwires that get missed in the body. That there's all kinds of tumor suppressor genes that turn on, that tell us stop. When there is a change in the metabolic milieu in the area where a tumor is developing, then a tumor suppressor gene can be turned on in order to stop a tumor from further growth. And exercise turns on tumor suppressor genes, a number of different tumor suppressor genes. We also
So
know.
can I ask one question? So what I hear you say is that if I, let's say, haven't been treating my body very well, and I have a tumor suppressor gene that got turned off,
Right.
the exercise can turn it back on.
Correct.
So that's pretty interesting that it can actually change your genes to make it an environment
Expression of the genes.
Wow.
Right. So there's an alteration in tumor suppressor genes with exercise. There's also in our cells, and every cell, we have what's called the powerhouse, the mitochondria, which are the things that express all of the energy and help us with making the work of the body happen. The way that the mitochondria metabolize alters in tumors as a result of being more physically active as well. So the ability of the tumor to continue to metabolize and do what it needs to do in order to grow and grow and grow and grow, because it's, a tumor is uncontrolled growth. That's what a tumor is. And it's less able to do that as a result of being more physically active.
Wow.
So
it's interesting.
There's also enormous effects in adipose tissue, so our fat tissue. One of the things that has been shown, there's a small army of researchers that have looked at what happens in the fat tissue of individuals who are sedentary and overweight, as opposed to people who are regularly physically active and or lean. And those two things tend to go together, but are not necessarily, there's kind of a Venn diagram. It's not perfect, but the adipose tissue in somebody who is sedentary has more cytokines, more inflammatory constituents, okay? And those inflammatory constituents alter the adipose tissue in a way that it starts to degrade the actual adipose cells so that they become crown-like structures, which are very inflammatory, which wreak havoc in terms of inflammation and altering suppressor genes and tumor promoter genes, and alter the metabolic milieu in which a tumor would grow. And we know that adipose tissue just looks sick in somebody who is sedentary. And adipose tissue, the same adipose tissue, I'm not asking you to lose the adipose tissue, I'm asking you to make your adipose tissue healthier, right?
Who
So
knew there was healthy fat? That's so
there is healthy fat.
fascinating. I've never heard that before. That's
Yeah,
interesting.
right. So the other thing is that, so basically what I'm getting at is that there are changes in the expression of genes, there's changes in metabolism in tumors, there's changes in adipose tissue, and extremely importantly, there are changes in the way that our immune system works. In particular, we've known for decades that exercise has a positive effect on the number and function of natural killer cells, which are extremely important for killing tumor cells and fighting off the development of tumors. So, so our immune system is altered by exercise. We've known that for a long time, frankly. We're just getting more information. We have a J-shaped curve with an upside down J-shaped curve with exercise and immune function that's been described for a very long time. People who are sedentary, their immune systems are weaker. We know this from COVID. Do you know
Yeah.
that? We knew this from COVID. People who are regularly physically active are way less likely to develop long COVID, develop severe COVID, be hospitalized from COVID. That's been published in major journals, right?
Yeah.
So there's your proof, right? So we know that exercise has a powerful effect on background immunity, all right? But in addition, there's this other system, if you will. It's not really a system, but for sake of argument, it is. And that is our inflammatory system. Like the level of background inflammation in the body is quite different in someone who is sedentary than somebody who is regularly physically active.
And meaning higher in those who are
Higher in those who are sedentary. And if it's higher, then that means that there are more cytokines that are coming in, and there's more free radicals that are coming in to the metabolic milieu around tissue that is thinking about becoming a tumor or is in the process of becoming a tumor, or a tumor in the process of growing and moving and invading to other territory. And those free radicals are saying, great, let's have a party. Let's make that happen,
All right, we got to shut down that party.
We got to shut down that party, and exercise will shut down that party.
Wow, interesting. There's a new I kind of cut you off and veered the conversation, but you were getting to the topic of high intensity training
Oh,
and
yes.
vigorous exercise. So we had gotten through, okay, this is the process to go through, in your cancer journey. But what about this new conversation that's happening about vigorous exercise and the research in that area? I think you've had some experience with that and one of the researchers.
Yes. So Dr. Stamanakis published a paper in JAMA Oncology this past summer that got a lot of splashy press. And he was talking about an observational study. So again, caveat, lots of, caveats about all of the various types of research. And Dr. Stamanakis was working with the UK Biobank, which is a remarkable observational study that has followed tens of thousands of people over the course of a very long period of time. And they had them wear a physical activity monitor on the wrist, not unlike an Apple Watch. And they followed them over time to see who would develop cancer and who would not develop cancer. And what they were able to do, in part because of the precision of the data and because of the size of the cohort, they were actually able to look specifically not just at whether people were active versus not active, but specifically at intensity of activity because of the fact that they had objective monitoring. And people are not awesome at saying, it's like, oh, yeah, I went for a jog, and really, did you? So,
The wearables is a big advancement in research for that. I can imagine that the data is going to be much better. Will make the research much better.
Exactly. So, and what somebody calls a jog is going to be, different than what somebody else calls a jog. So he had this, really pristine data to be able to analyze. And what he was able to isolate was that, in fact, there was tremendous isolated and interesting usefulness of what he called VILPA, vigorous leisure time physical activity. And what he was interested in was that he was able to show that bouts of 2 to 3 minutes of vigorous intensity physical activity had a meaningful substantive effect of reducing risk of incidence of all cancers. He didn't look at specific cancers. And so, this is very interesting. And, the challenge, and we've talked about the behavioral challenge of being physically active. The challenge is that people say, you want me to do 150 to 300 minutes a week of exercise. Exactly when I'm dealing with kids and
Mhm.
job and cancer and, everything else I'm doing. And so what this paper basically says is that, it is possible that we could get benefit from doing something very vigorous. Let's just drop into some burpees right now. Let's, get into the jumping jacks. Let's high knee,
Mhm.
marches, whatever we might do that would be high intensity, and do it for 2 minutes, do it for a minute. And, maybe doing that a couple of times a day is beneficial.
Mhm.
What I would say is that we don't have any animal model studies yet. We certainly don't have any clinical trials in humans looking at biomarkers. So it's kind of early days
Uh-huh.
with these data, but they are very promising. And I think that they are consistent with what we know about vigorous intensity activity and heart disease. So I tend to think this is, kind of a promising new avenue. And I think that importantly, behaviorally, it is, I am interested in increasing the degrees of freedom by which people can adhere to an exercise program. And if somebody listening says, yeah, I can do that. I don't want to do a half hour a day, but I can do that. More power. That's
More
great.
power to them.
Yeah,
Yeah,
go for
it makes me think about my mother-in-law who loves to have spontaneous dance parties. She'll just turn on the music, put on some jazz music, and then just start dancing for a couple of minutes. She wants
Great.
everybody to get up and have a party. And that doesn't sound like such a bad thing for a
Yeah.
cancer patient to do a couple of times a day. And it may actually even help you from an uplifting attitude perspective where you can laugh a little bit, which we know
Right.
laughter is beneficial for as an anti-cancer strategy. And so, pulling all that together into a 2-minute dance party a couple times a day might not be a bad way to start.
Well, and so you're inspiring me to talk about, exercise as play. And, one of the things that I have a colleague, Chris Yamana at Penn State, who thinks that we've really missed the boat with saying exercise is medicine, because then it's like exercise is medicine. It's very serious, and it doesn't need to be. And I think behaviorally, if people are thinking, I get to play, I get to do something that is play, they're
Mhm.
more likely to do the exercise and adhere to the exercise, as
Mm.
opposed to, I must do, 30 minutes of walking,
That's a really good point. It's a really good point because, okay, I have a meditation that I do. I listen to someone who's a student of Wim Hof, and he's got the best voice I've ever heard. And
Mhm.
so I'll listen to this, and at one point, um, he says, okay, so it has you tracking what's happening in your body. And at one point he says, okay, now just put a small smile on your lips, just a little one, and
Got
see
it.
if that makes you feel differently.
Yeah,
And I'm always amazed at how
yeah,
it does. Just
yeah,
putting a little smile on your face and how you can just, your whole body feels a little different. And I can imagine that if cancer patients are thinking about moving as something they get to do, as a get out of jail free card, or a hall pass, right? Like a free pass out of school for a little while, out of your job for a little while, to go have fun for a few minutes, a few times a day. you know that might make them feel different inside.
yeah, absolutely, absolutely. I think we all feel better when we move, but I think that if we can find ways to move that are social and that connect us to, other people that we love, I think that the likelihood that, we know that, when people have social support around their exercise, they're much more likely to adhere to it.
So do you think that patients and people know that exercise is beneficial to cancer?
I don't. I don't, unfortunately. I think that the average person on the street if you walk up to them and say, hey, your Aunt Betty has ovarian cancer, and she's going through chemotherapy, do you think it would be a good idea for her to exercise? Most people would think you're odd and say, no, she should have a blanket over her knees and a cup of tea. And so I think we need a paradigm shift. Our evidence base and public knowledge do not match at this time. And I like to tell a story to explain this situation. In the 1950s, sitting President Dwight Eisenhower had a heart attack. People don't remember this, but he did. He was sitting president. Imagine that today. That would be such a media hoopla.
Be a frenzy.
So yeah. So he had a heart attack, and his cardiologist at Bethesda Naval, Paul Dudley White, very famous cardiologist, was sharply criticized for getting him out of bed so soon, 3 weeks after his heart attack. Which today we all say, oh my gosh, we get people out of bed the next day, we get people out of the day, out of bed, within days of having a heart attack. And we know now that exercise is quite good to repair a damaged myocardium, a damaged heart, right? And so, if you ask the average 8th grade educated person in the United States, is exercise good for the heart? They're going to say yes. And they're going to, if you ask somebody had a heart attack, should they exercise to recover? They're going to say yes. The American Heart Association has done an outstanding job over the intervening decades getting that message out. They have beautiful programs all the way down to junior high students to help people in the United States to understand the connection between exercise and heart disease. Okay, so we need a similar paradigm shift. We need an army of people to help us, and we need large organizations to help us to help patients and, frankly, clinicians, nurses and doctors, to understand that exercise is valuable for people living with and beyond cancer.
Excellent. Excellent. And it is doable. It really is doable. It's just going to take some dedication. So we hope to be a part of that.
Fantastic.
Yeah. Yeah. So this has been an incredible conversation. I thank you so much for all of your time. I want to just wrap up and ask you if there's first anything that cancer patients can do to help you reach your goal. How can we help you in getting exercise approved as an important treatment in standard care for cancer patients?
Demand of your cancer clinic that there be an infrastructure and actual human beings to help you with your exercise.
Okay.
Make sure that your cancer clinic understands that it is not good enough to hand you a prescription, and it is not enough to hand you a brochure. That you actually need an infrastructure, you need a program, and it can't be just Tuesdays at 7 o'clock at night. And there needs to be more infrastructure for exercise. There needs to be rehab navigators, and there need to be people to actually offer you programs.
Is there a place where we can direct them to? Is there an infrastructure through, I don't know, American Cancer Society or something like that, where if they need help figuring out what that infrastructure should look like, where they can go?
Well, there's a place we've actually searched for and identified. There's a directory of 2,133, not to put too fine a point on it, but 2,133 programs that are cancer rehabilitation and exercise oncology programs across the United States. That directory is available. You would Google for ACSM, that's American College of Sports Medicine, and Moving Through Cancer. Note that we've triangulated everything around the phrase moving through cancer.
Yeah.
The book, the initiative at ACSM. And so there is a directory there. And I'm not hard to find on the web. Folks can certainly email me if they have questions about how to get a program set up at their particular cancer center. I'm happy to be helpful.
That's awesome, because I think that it is really powerful when cancer patients can come in armed with a piece of paper to say, and if you don't know how to do this, contact this person and they'll help, they'll help get it done.
Right.
So that's awesome. So all of you cancer patients out there,
Yeah,
we can help.
I lead the Moving Through Cancer Task Force, which is a consortium of, international consortium of experts, including a medical oncologist, an oncology nurse, physical therapist, lots of exercise physiologists, there's behavioral scientists, et cetera, et cetera. We are writing a national coverage determination application to CMS to get Medicare coverage for exercise oncology through CMS, and would be great to get a couple of patient advocates on board to write testimonials to say, this is really important. We really want this to happen.
That's wonderful. I will make sure that in the show notes and on the website outperformcancer.com that all the information is there, so that people can look it up and we can redirect things back to you. So that's super exciting. And then finally, can you wrap us up with a 1 to 2 minute summary of what should every cancer patient know about exercise and cancer?
You are going to feel awful as you go through your cancer. This is true. You have choices. You can decide that you are going to feel awful as you go through cancer and lose function and muscle, or you can choose to try to stave that off. When you are done with your cancer, I guarantee that you are going to have lost muscle and function. The amount that you lose depends on you. I absolutely understand that for some people, this is just not tenable. In that case, get going afterwards and regain all that you can. I never want to prescribe something to someone that is not possible. So I do understand that some people are going through a type of cancer treatment that it just simply is untenable for them to exercise as they go through. But for those of you that can, I guarantee you, it will make you feel better.
Thank you. What a great conversation. I think we're going to help a lot of cancer patients. And I just really appreciate your time. Thank you so much.
You're so welcome. Thank you for the opportunity.
And now an important announcement. All the information that was provided today was for educational purposes only. I'm a patient, just like you. I am not a licensed or accredited physician, therapist, or clinical researcher. All information provided is not intended as a substitute for the advice of a physician, therapist, nutritionist, or any other qualified healthcare professional.